Today's topic is sort of unique because it's one of the hottest topics in cardiology and one of the most controversial, but one of the oldest problems facing us as doctors and cardiologists about hypertension. And recent studies and trials have raised very seminal issues about how low to go, and that's the topic that we're going to talk about. Just briefly, our illustrious panel is going to be led by our visiting professor, Clyde Yancy, who's Vice Dean for Diversity and the Magistrat Professor of Medicine and Chief of Cardiology at Northwestern. In the panel will be Asilma Felgers, who's National President, Association of Black Cardiologists, board member of New York City and Founders Affiliate, American Heart Association, and director of Mount Sinai Heart Center for Cardiovascular Disparities. Also on the panel is Lawrence Krakoff, Professor of Medicine and one of the leaders in the field of hypertension, Mary Ann McLaughlin, Medical Director, Cardiac Health Program, and Clive Rosendorf, Professor of Medicine and Director of Graduate Medical Education at the VA Medical Center, also been a pioneer for many years in hypertension. Our moderator for this session, we're privileged to have our own Valentine Fuster, who's Physician-in-Chief of Mount Sinai Hospital, Mount Sinai Medical Center, Director of Mount Sinai Heart, and editor of Journal of American College of Cardiology, which has the impact, has the largest and strongest impact factor of any specialty journal published, which is quite a statement. The topic for the controversies, as I said, is hypertension, how low to go, which is a fascinating subject, and we're privileged to have Kimberly Hung as our cardiology fellow, who will give everyone a brief overview.
Great. Thank you, Dr. Yancy, for joining us here. So hypertension is a known risk factor for the development of stroke and cardiovascular disease, including coronary artery disease, heart failure, cerebrovascular disease, and peripheral vascular disease. An estimated $48 billion is spent on both indirect and direct costs annually. With nearly 1/3 of all U.S. adults afflicted by hypertension and only 75% of these individuals being treated, the opportunity for averting morbidity and mortality is significant. The pathophysiology of how hypertension develops, and in turn results in maladaptive remodeling and morbidity, differs by the comorbid conditions associated with it, as well as individual patient demographics, in particular age and race. Take, for example, kidney disease and hypertension. If it is kidney disease that precedes hypertension, it is hypothesized that dysregulation of sodium excretion results in volume overload, with resultant peripheral artery vasoconstriction. If it is vasoconstriction of the arteries that occurs first, vascular endothelial cell dysfunction results, which in turn causes dysregulation of smooth muscle. Chronic hypertension in turn causes glomerular damage and ischemic glomerulosclerosis. Both ultimately cause dysregulation of the neurohormonal axis, which further contributes to renal dysfunction and cardiovascular morbidity and mortality. Volume management and neurohormonal blockade are the mainstays of treatment in this patient population, with early studies showing improvements in outcomes with just initiation of ACE inhibitors and ARBs. African Americans are another important subpopulation. Approximately 40% of all African American adults are afflicted with hypertension, compared to approximately 30% of all white adults. In addition, the age of onset is typically earlier and the average blood pressure higher in African Americans compared to whites. These differences in the prevalence and epidemiology of hypertension in African Americans alludes to there being a different pathophysiology of disease. From a genetic perspective, sodium channelopathies have been identified, which lead to sodium transport defects, as well as lower levels of natriuretic peptides, renin and kinin. And the different prevalence of hypertension in African Americans born in southern versus northern states also suggests that environmental factors such as diet and BMI may contribute as well. The higher burden of hypertension has translated into increased cardiovascular morbidity in African Americans, as well as vascular and end organ remodeling. This is all thought to be mediated by RAS. Hypertension treatments that consider the pathogenesis of disease have been shown to be more effective. Specifically, thiazide diuretics, because of increased salt sensitivity and calcium channel blockers, have been shown to be more effective than beta blockers, ACEs, or ARBs as monotherapy. A multi-drug combination should include an ARB with a diuretic or calcium channel blocker. Ideal blood pressure remains a moving target. In addition to considering how variables such as trends in cigarette smoking, obesity, population demographics, and advances in medical therapies, such as lipid management and antiplatelets, that alter cardiovascular disease, individual patient risk factors must also be considered when determining ideal blood pressure targets. In accordance to recent clinical trials, hypertension guidelines have raised target blood pressures for high-risk patients, including those with diabetes, cerebral vascular disease, chronic kidney disease, and coronary heart disease to 140/90 from 130 millimeters of mercury. Even more controversial has been the increase to 150/90 in the greater than 60-year-old population by JNC8. To highlight the complexity of this issue, less than 2 years from when JNC8 was released, the pendulum may again be swinging in the opposite direction, with the recent publication of the SPRINT trial, which showed a significant reduction in cardiovascular events and deaths for those randomized to an intensive systolic blood pressure goal of 120. The SPRINT trial was an NIH-sponsored multi-center randomized control trial that compared an intensive blood pressure treatment strategy defined as systolic blood pressure less than 120 to a standard blood pressure treatment strategy of less than 140. The patient population included individuals older than 50 years with an increased cardiovascular risk profile, defined as CKD with an estimated GFR between 20 to 59. A history of cardiovascular disease, either coronary, carotid, or peripheral, left ventricular hypertrophy, a 10-year Framingham cardiovascular risk score greater than 15%, or older than 75 years of age. Notably, individuals with diabetes, prior stroke, significant proteinuria, end-stage renal disease, or polycystic kidney disease were excluded. The primary outcome was a composite of MI, ACS, stroke, acute decompensated heart failure, or death from cardiovascular cause. Safety outcomes included worsening kidney function. A total of 9,361 individuals were randomized between 2010 and 2013. Median follow-up was 3.2 years before the trial was ended early because of positive results. The primary composite outcome occurred 1.65% per year in the intensive treatment group compared to 2.19% in the standard group, which translated to a relative risk reduction of 25%. The composite endpoint was driven by the heart failure outcome, which was defined as any ED visit or hospital admission requiring intravenous therapies, as well as cardiovascular deaths, which included coronary, heart failure, stroke, vascular, and sudden cardiac deaths. Interestingly, in terms of secondary endpoints, there was no difference in rates of MI, ACS, or stroke. This trial and its impact on clinical decision-making for the treatment of hypertension is the topic of tonight's controversies.
Thank you very much, Kim. You try to attack a problem that is complex, but I hope that the session today will provide some light, which is the issue of hypertension. It's a pleasure to introduce Dr. Clyde Yancy today. He is one of these giants in the cardiovascular field, and I just will spend no more than 3 or 4 minutes making what I consider is an appropriate and legitimate presentation. Clyde was actually obtained the MD degree in 1982 at the Tulane University, and then he spent 2 years, interestingly, in getting a degree in healthcare management at the University of Texas Southwestern. Now, it was actually in such a university where he had his internship, his residency, and his fellowship in cardiology, and in addition, he underwent advanced training of heart failure and transplantation with in 1990 and 1991. Well, subsequently, he became a staff member at the University of Texas Southwestern in Dallas, where he was from assistant professor to professor of the Department of Medicine. Now, it was in 2006 where he moved to Baylor University Medical Center in Dallas, where he became chief of cardiothoracic transplant services and medical director of the Baylor Heart and Vascular Institute. He was there until 2011 when he actually moved to Chicago as chief of the Division of Cardiology at Northwestern University, associate medical director of the Bloom Cardiovascular Institute, and vice dean of diversity and inclusion. He there, of course, had his academic appropriate promotions, and he became the Maxted Professor of Medicine at the Department of Internal Medicine and Professor of the Department of Medical Social Sciences. Well, he really is a very outstanding life professionally. He has been recognized with very important awards and honors. I would just mention 4 or 5. Ellis Media Award from the American Heart Association, National Physician of the Year of American Heart Association, Outstanding Teacher 2005-2006 of Southwestern Medical Center in Dallas, the Charles Richard Rowe Award for National Minority Equality Forum, American Heart Association Distinguished National Leadership Award, Gold Heart Award of the American Heart Association, Educator of the Year, a National Medical Fellowship, Northwestern Medicine Excellence in Teaching Award, in the AHA Lennec Clinical Educator Award. But just to give you a sense, these are not cheap awards. These are real. All right, so here we have his professional and scientific service, American Heart, American College, NIH, Food and Drug Administration, and just to give you a sense of who is he. Here you have American College of Cardiology. He was the chair of the ACC-AHA Heart Failure Guidelines. American Heart Association, chair of the Heart Failure and Transplantation Committee of the Council on Clinical Cardiology, chair of a Strategic Assessment Group. And if you had not enough, he was president of the American Heart Association between 2009 and 2010. Subsequently, chair, together with the guidelines of Heart Failure Subcommittee and chair of the scientific meetings of the AHA in 2013-2014. Food and Drug Administration, chair of the Circulatory System Devices Panel, and in National Institutes of Health, member of the Advisory Committee to the Director, member of the Scientific Management and Review Board. Well, with all these accomplishments, it is obvious that he's in the editorial board in all the suspicious journals. Circulation, he really is into it. Circulation guest editor, Circulation editorial board, Circulation heart failure editorial board, Circulation quality and outcome editorial board. I'm not sure you made the right choices, but anyway, I must tell you that you have 2 positions in the Journal of the American College of Cardiology, in JACC, Senior Section Associate Editor of the Heart Failure. American Journal of Cardiology, he's in the editorial board, American Heart Journal, ACL, and so forth. In JAMA now, Deputy Editor of the new JAMA Cardiology. Now, Grant Awards, he has 10 NIH awards, either as a principal investigator, co-investigator, or basically as an advisor in the executive committee. And in terms of publications, he has near 300 publications that really, the publications go along the, a number of fields, heart failure, of course, transplantation, and pharmacology. Well, I finish. I think you got a feeling who is here today, and I really appreciate your visit, Clyde, and let me tell you, I have a plaque for you. Here it is. If you can come, then give it to you. You have a lot of words here, but basically goes to you. And this is the check. Well, now for this subject of transplantation, there are lots of people here. The subject may be simple. You, Clyde, you sit in the middle. And then we have Dr. Felgers, as was already pointed out by Dr. Goldman, Dr. Larry Krakow, Marianne McLaughlin, Clive Rosendorf, and then, of course, Kimberly Hong, who made the presentation. I am going to ask the panelists a favor, and the favor is please don't extend yourself into more than 1 minute or two, because it's so much to cover that we cannot go on and on and on here. So we are going to actually cover 13 different subjects, which are going to be divided in 3 parts. The first part is straightforward, is what we are talking about. The second part is about the history of the guidelines from 1977 to 2015. And the third is the so-called resistant hypertension, where we have to address not only sympathectomy, but many other things. So we are going to start with the first few subjects related to the understanding of what we are talking about today. And Clyde, I'm going to get to ask you your opinion about the first 3 subjects. First of all, hypertension is today the #1 killer if you really look at a single factor that leads to death across the world. So we are dealing with a subject that is a #1 in terms of trouble. #2, it is interesting that actually the people who are being treated properly for hypertension are only 25%. I could give you all the figures. I don't think it's necessary. It's just to give you the facts. And that is there is 75% of the people today with hypertension that either are inappropriately treated or are not treated at all. And only 25% are actually treated properly. And this leads to the third subject. Should we be talking about the so-called genomic era, precision medicine, and so forth, when people are not taking the drugs? This is like really going out of control. I like your opinion about the 3 aspects I mentioned. Yeah, it's okay.
Thanks very much, Val, and thanks to everyone for your hospitality today. So I'll stay within the 1-minute guideline. So I fully endorse the notion that hypertension is among the most, if not the single most important contributor, particularly to worldwide global cardiovascular morbidity and mortality, whether it's because of what it does to strokes, developing cardiovascular disease, or renal failure, which we shouldn't overlook. I do think that it is such a broad problem, and it is present in so many different communities, that taking a precision medicine or genomic approach really is a misdirect. This really has to be a public health initiative that I think has to be owned by providers outside of medicine per se. This is a great opportunity for community engagement. We've certainly done projects before where we've used barbershops and we've affected control of blood pressure. And I think similar such models need to be considered. I think the real question, though, on the table is, even after we find the right delivery system and the right way to make people aware, do we have all the tools necessary that we need to change the natural history of hypertension by treating patients in the correct way for the correct indication with the right targeted therapy? And I think that really is the substance of what we're dealing with now, especially in communities that have limited resources. How can we find the right intervention to have the maximal effect?
You did so well that I'm going to ask you a second question. And it's very simple. We are all aware that hypertension is more common in blacks than in whites. Okay, 40% in one group, adults, and 30% in the whites. And I just want to point out that it seems to me, by reading the most recent literature, what is the reason for that? And I have 2 factors, and I'd like you to comment on, since you have been working on this. One is this increase in arteriolar stiffness that happens with age, particularly, but is more prominent in the blacks. And the other, something that appears to be quite intriguing, and you didn't mention this today because you talk about the consequences of hypertension rather, is a problem with the sodium entry, the so-called sodium channelopathies, which may explain why diuretics are probably the best approach to such particular group of patients. I'd just like to comment about this subject between blacks and whites and the mechanism of hypertension.
So I think both of these variables are important. I am refreshed in my mind by the Bogalusa heart study done by Jerry Berenson out of LSU. It didn't receive a lot of medical literature exposure, and it should have, because in children, African American children as young as 10 years of age, there's already demonstrable evidence of stiffness, vascular stiffness. And so the substrate is there to develop a hypertensive experience within the second and third decades of life, which is pretty extraordinary when you think about the consequences of hypertension. And so I do believe that there is at least the component of arterial stiffness that contributes to earlier onset of disease and potentially a more pathologic natural history. I'm more intrigued, though, with this notion of the sodium handling characteristics that may vary. Time won't permit a full and elaborate discussion about this, but there may be some inclinations in the African American progenitors to have a very different amount of sodium handling, and that may in fact be something that's continuing to drive some of the renal pathology that we see, as well as cardiovascular disease. To the extent that that intersects with what we described earlier today, thinking about the GNB3 genotypic variants, that is something that's still left up for further discussion. But I would say that both of these are contributors to the burden of hypertension. But we understand that this is a complex disease. It seems simple when you talk about blood pressure, but the biology is anything but. So I would support both changes in arterial impedance and changes in sodium handling as part of, but not the sole contributors to the burden of hypertension that we see in African Americans.
Okay, thank you. Dr. Krakow, why we don't measure stiffness, if it is so important?
Well, I think partly it's, as brief as I possibly can, that arterial stiffness has been recognized in the lab for decades. Clinically, it's still, I think, under-recognized, and the measurement is a problem. Is there a good measurement of stiffness apart from blood pressure? So I think partly it's a conceptual gap, and partly it's a measurement need.
Dr. Rosendorf, there's something very peculiar in the history of hypertension. We will discuss this in detail in a few minutes, but years ago, the whole issue was diastolic blood pressure, and the guidelines were diastolic blood pressure less than 90. Nobody cared about systolic blood pressure. Then this moved a few years later in systolic and diastolic blood pressure. We all remember the 140, 90. And more recently, nobody cares about the diastolic pressure. The whole issue appears to be the systolic pressure. What has happened is because they have found that the higher risk is in the systolic pressure and the rest is not important. What is the problem?
I'm old
enough.
I'm old enough to remember JNC1, which I think it was in the mid-1970s, in which the recommendation was that you should not treat hypertension unless the diastolic pressure was clearly above 110 millimeters of mercury.
I was a medical student.
Really?
I remember, absolutely.
And well, we've come a long way since then, and I think the trend has been for all of those numbers to go progressively downward. And SPRINT is just another step in that inexorable historical tradition. What about systolic versus diastolic blood pressure? Yes, the epidemiologic evidence is that there is a closer correlation between systolic blood pressure and adverse cardiovascular outcomes, and I think that is clear. But as cardiologists, we've got to think about the physiology of the coronary circulation, which and understand that myocardial perfusion is almost entirely during diastole. So there has been an underappreciation of the importance of the diastolic blood pressure in understanding coronary outcomes in all of these clinical trials. And perhaps we can talk a little more about the diastolic blood pressures in some of the major clinical trials that we're going to get onto, including SPRINT.
Yeah, we'll talk in a moment about it, but it's quite fascinating, isn't it, the change. Kim, you have 3 pages related to the J form of hypertension. Let me tell you what I'm talking about, because I like to really get into this. Now, a number of studies have suggested that if we lower the blood pressure too much, there is underperfusion, and this has been a problem, at least suggested problem, in renal disease, in diabetes, in cerebrovascular disease, and even in coronary artery disease, which made the history of guidelines, as we will mention in a moment, to fluctuate by actually first dropping the blood pressure as much as possible, but then beginning to go up again, thinking that this underperfusion is a reality. I read in detail what you wrote, and finally I reached the present conclusion, and that is not such a problem. Is this your conclusion?
I mean, it seems like in terms of the studies that I went through with the J curve, that there may have been, a lot of the epidemiological studies anyways seem to have showed that correlation a little bit more persuasively. But when you looked at the randomized control trial, depending on how they actually did their analysis, it seemed like the J curve phenomenon did not really pan out, at least in the CAD patients, and as well as the CKD patients as well. It seemed like primarily there was a little bit more of a correlation within the diabetic patient population. So at least that's what I was able to see. There's a thought that part of it may have been that the comorbid conditions that are associated with a lower blood pressure may have been driving some of those results that we are seeing, that the lower the blood pressure, that there were different things that may have contributed to that would have then caused a higher mortality, and not necessarily it being a causal relationship.
Marianne, it seems to me, though, that the hypoperfusion is a problem in your head. And that is, it's very interesting, because all the trials talk about incredible number of events, which then when you really get into the trials, is very hard to find out. But we have how many people we see in the aging population, if you drop the blood pressure below 130, the patients begin to stumble.
Correct. I think that one thing that's not mentioned in SPRINT, and we haven't talked about yet, is carotid artery disease. So we know that if you have bilateral carotid stenosis, that dropping the blood pressure, that's the one subgroup of people will have cognitive events or cerebral events. But I think that in this, this study was phenomenal, and it's in a select group of patients where they excluded, resistant hypertensive patients with diabetes. We have patients who are over the age of 75 in this group, and it's one of the 3 leading studies now in the older population. But I think that by excluding patients with prior strokes, we've actually minimized that. But I think that some of the complications with the fainting, syncope, orthostatic hypotension may be related to the brain.
Yeah, but there's one issue, Dr. Felgers, and that is this is all what they always publish things that are dramatic. But when you see patients every day, you realize that the things that are not dramatic are affecting the patients and are not in the literature. We see constantly the issue of dizziness in the elderly. And the question that we'll discuss in a moment, to drop the blood pressure less than 120, is fantastic for those who are in a desk and they don't see a patient. But those who see patients know that that's not the case. It's a problem. Are you in agreement, Dr. Felgers?
The issue that I see with a lot of my patients, they're non-compliant, and they tend to have elevated blood pressure. So this whole issue of having hypoperfusion and low blood pressure, many of my patients being African American, is very, very important. We know that at blood pressures that begin to become elevated, even as much as 130 over 80 or so, you're beginning to see end organ damage, which is particularly important in African Americans because they begin to manifest severe outcomes from elevations in blood pressures at lower blood pressures than the Caucasians or other ethnic minorities. So, I mean, I know we were talking about hypoperfusion, et cetera, but I'm a firm believer that the lower The blood pressure for African Americans is important. I think that the J-shaped curve does not necessarily apply so much to African Americans. There may be a flattening of the curve. And I think that when you look at recommendations, for instance, from ISHIP, the Intersocietal Hypertension for a Society of Hypertension in Blacks, they recommended even before the SPRINT trial that patients, their blood pressure should be 130/85 in general, and if they begin to have issues with renal insufficiency or diabetes, then they recommend an even lower blood pressure.
Yeah, we'll talk in a moment, but
Right.
the important thing is you should know your patient.
Yes.
Now, how we measure blood pressure? I really like to get into this because this is an issue in the trials that has been extremely controversial. Dr. Rosendorf, this is what I learned. You can measure the blood pressure in 3 different ways. One is in your office, and you may be 50% chance that the patient has the so-called white coat syndrome, which, by the way, is prognostic too. We cannot discard it. The other is you can measure the blood pressure with these ambulatory cuffs day and night. If you have a good day, the blood pressure may be low, but if you have a bad day, maybe in the sky. So, and then it's expensive. And the third is to measure the pressures once a day at home, let's say over a period of a week, every day at a different time. This is cheap, and I think you get an average. Which one do you choose? Before we go into the trials.
Well, the accepted norm for blood pressure definition is an average blood pressure over 24 hours, and I think the 24-hour ambulatory blood pressure monitoring values are probably the most valuable. I don't think there is a very large day-to-day variability in the mean daytime and nighttime blood pressures, in fact. There is a very large variability in the sorts of measurements you get in the clinic or in your office. The common scenario is that a patient is late for an appointment, can't find parking, rushes up the stairs, had an argument with their spouse, and is whisked into a little room to have their blood pressure taken. And generally, those blood pressures are an overestimate of what their daily blood pressure is. So I would appeal to everybody to repeat the blood pressure measurement after the patient has been in your room for at least 10 or 15 minutes in a quiet room, sitting quietly. What about...
Excuse me, this is nice to say, but we don't have those 15 minutes. What I'm saying is, no, this is important because there are lots of guidelines here.
Yes.
But what you should do is like if you go to the Ornish diet, you would meditate 7 times a day. You don't have time to work.
Yes.
I mean,
Well,
let's...
this is not an ideal world, and I understand that.
No, but it's important. We are doctors that are dealing with our patients, and these 15 minutes, can you imagine you go to work and you are excited or are anxious? Those 15 minutes of being completely at rest, just thinking on nothing happened, to me it means nothing on the daily life.
Yes. No, I accept that completely. And we understand that what we have to do is to correlate the blood pressures that we see in the clinic with the clinical trial evidence, which are based very largely on clinic blood pressures, to try and get a risk estimate or to stratify those patients in terms of risk. But I do agree with you that daily blood pressures at home by the patients is also extremely useful and much perhaps more useful than the isolated clinic blood pressure. The problem about daily blood pressures is that patients get a little obsessed by their blood pressure and they get a little bit neurotic about their blood pressure.
Except you tell the patient to do it once a day. The problem is the patient who checks the pressure constantly during the day, but if you tell the patient every day at random, a different time, you get 10 blood pressures and you get a mean that tells you what is going on.
Well, in most patients, I tell them 2 or 3 times a week, and that's probably enough.
Larry, your view of what is the best method? We are not on a trial, we are doctors right now.
No, I'm a doctor, and I see patients, and I have switched over to home blood pressures for the 80%, and I'm trying to weed out the 20% of those who are fixated on it. But there are now at least a half dozen national guidelines that have recommended ambulatory blood pressure monitoring as the standard. The United States and the Preventive Task Force, Canada, Australia,
The ambulatory.
the ambulatory.
Yeah, but I'm sorry, this is because our trials. I don't think,
this is
I like Clyde to comment in a moment, but no, I just want to continue with you. These are trials, and then you have the 24 hours. What about if you have a bad day? Your pressure is going to be in the sky those 24 hours. This is not an average. It depends
There's
the
a
day that you
bad day
have.
and there's a bad day. Those, we've monitored a lot of people, so you occasionally find a bad part of a day rather than a bad day. So if someone has a blow up in mid-afternoon, by the time the rest of the day has gone by, including and probably especially important, our blood pressures during sleep, which seem to have the best single correlation within the 24-hour strategy for a correlation with eventual target organ damage. So I'm recommended.
Clyde, can you make peace here?
Well, yes, no, I agree with Larry. I think that 24-hour ambulatory blood pressure monitoring is the gold standard.
I meant the other Clyde.
Oh, sorry.
No, you were okay. You were okay.
You must say V or D.
We'll figure it out.
I was told this was a lively session, so there it is. I think we're talking about an imperfect surrogate marker and giving it more precision than it merits. And so, as a practitioner who sees hypertension, I'd stick with one approach. It's the home blood pressure. I recognize there's going to be a lot of noise in the signal. Where the ambulatory blood pressure monitor makes some sense to me is a young person who seemingly has a greater burden of end-organ disease. I'd like to look for evidence of dipping, non-dipping. That kind of gives me a sense of what may be exaggerating their disease. But I like to use the same approach and really understand that we're talking about qualitative changes. We can't be too precise with blood pressure.
Thank you. Okay, so we finished part one, which is, just the beginning of what is going to be much more hot here. Let's go into the history of all these guidelines and so forth. And Dr. Felgers, I'm going to focus in 4 different times between 1977, when the first reports from the NHLBI evolved with the Joint National Committee, to 2003. And then from 2003, we will go into 2015, and then we'll move forward into what happened in the last few weeks, because this has been moving very rapidly. Let me now focus into what went on between 1977 and 2003, and I summarize in just 1 minute, and I'd like to know your opinion. So the Joint National Committee from the National Heart, Lung and Blood Institute really got involved with blood pressure over the years. And we have now 7 committees, and then the 8th one, people divided themselves, and some gave up and some stay in, which we will discuss. So let's start in 1977, when the first 3 JNC advisory committees gave the guidelines. And what is interesting at that time is a diastolic blood pressure, I'm talking 1977 until 1985. At that time, they talk hypertension, a diastolic blood pressure of more than 90 millimeters of mercury. This was hypertension, and you should reach a therapy of less than 90 millimeters of mercury. I repeat, diastolic pressure. Then after these first 3 JNCs came the 4th one, and this is when they decided that perhaps the systolic pressure should be taken into account. And then the guideline with the JNC 4 was less than 1/40/90 should be the goal of therapy. In 140 and 90 or over, it would be hypertension. Then came a very interesting study, which was the SHEP study. And the SHEP study basically was focused on systolic blood pressure in the elderly. And that study was so well done that people moved from diastolic pressure to diastolic, systolic, into systolic pressure based on a study that was just measure systolic pressure alone, at least in terms of the meaningful results. And from that SHEP study, now we have the JNC number 5, which basically what they say, take care of the systolic blood pressure and forget everything else. And what they took is 140 millimeters of mercury or higher means hypertension, and 140 less than 140 should be the driving force. With exceptions that you might consider, and this is very personal, that you might want to have a pressure of less than 130 over 85, but that's aside. It's like a supplement, what they actually said. This is the JNC number 5. Now comes the 6 and the 7, and the 6 and the 7 are basically very similar, but they emphasize, based on the SHAPE study, that perhaps many patients should have a blood pressure less than 130. It's not too different than the JNC number 5. So here we are, and we arrive with this to 2003. And I'd just like you to give us a view of all of these. There are no significant changes. The most important to me is the movement from diastolic pressure to systolic.
That's a lot that you're asking me to do, but in 1 minute. But you know what? I think that JNC has come full circle. And you didn't ask me to comment on JNC 8, but looking at all the JNC summaries that you just mentioned, and we go all the way through JNC 8, that's the anomaly. If you go back, the earlier JNCs that you described, looking at diastolic blood pressures of less than 90, and then JNC 5, 6, and 7, you're looking at blood pressures of 130 over 85. Then you have JNC 8 that's talking about higher numbers, 150 over...
Just a moment, we didn't get there. That's another phase.
But anyway, my thoughts are that I think that we have come back to where we were, because if you look at the SPRINT trial, it's basically going back to what was said in those earlier JNC summaries, and I firmly believe that I support maybe JNC 5, 6, and 7, because they're more in keeping with what I've always practiced with my patients, and with what associations like the Association of Black Cardiologists have maintained all along, is that we should try to, deal with both systolic and diastolic blood pressures, and try to keep the blood pressures in the range that were sort of elucidated in JNC 7. I think focusing on the diastolic alone, as in the earlier JNCs, it's not something that I would recommend, because as we talked about before, looking at perfusion and hypoperfusion, et cetera, I think both systolic and diastolic are important when we're dealing with some of the complex patients that we have, that we're dealing with, especially the African American population.
Okay, Dr. Yancy, it seems to me that from the first 1977 to actually 2013, everything was more or less peaceful, because, things were moving, systolic, diastolic, but people were talking about the same numbers. Now, in 2013, it seems to me NHLBI got tired of everything, and they decided we don't want to be involved on guidelines anymore. The reasons are curious, but I don't think it's necessary to discuss this at this point. And then there was a takeoff. The American Heart made guidelines and so forth, the Europeans, but they were not too different than what really came up in the previous years. The whole problem was that once NIH said we are not interested, a group of the JNC got together again. And during the discussions, they split it. One group said, we don't believe. What do you want to publish? And the other says, I don't care, but we are going to publish it. And that's where the problem starts. And I hope I am correct into what I'm saying. Basically, what they decided, something was reasonably good and something was reasonably bad. What was bad, according to many people, is they said if you are over age of 60, you can have a hypertension not higher than 140, but higher than 150. And this actually came into the discussion. I would just say that reviewing the data, they really didn't have enough data to make that comment. They actually focused their attention on three trials that had very high blood pressures. They didn't have the lower blood pressures to make a comment. Is this correct?
Not only is it correct, it really goes back to the discussion that Dr. Felgers just had with us, particularly for the fellows. I want you to think about this. Whenever someone makes a statement about guidelines, you should immediately allow your mind to think about what's the evidence base. Guidelines should always, and have for the most part, been data-driven. The reason the early iterations of the Joint National Committee on the Detection and Treatment of Hypertension focused on diastolic blood pressure was that we had the predicate VA trials that enrolled at diastolic blood pressures of about 110 and showed a reduction in stroke. And so that drove those guidelines. And then we had a transition based on SHEP and other trials to look at systolic. But what was very, very important is that JNC8 had a philosophical change. There was an evidence review first, and only those trials deemed to be of high quality could then be used to inform the guidelines. And so it gave us this very awkward dynamic where there was no carry forward. It was starting from a blank sheet of paper and only looking at high quality evidence. So we got these different parameters primarily because the evidence to definitively show that treating to a blood pressure of 140/90 was responsible for improvements simply wasn't there. So one case in point is to take SHEP. SHEP is a highly regarded trial. Dr. Fuster just endorsed it. But the treated systolic blood pressure in SHEP got nowhere close to 140. Yet we saw these incredibly good outcomes. The dilemma was that it was such a cultural digression for us that we rejected what the JNC original 8 committee put forward because it was so contrary. But if the fellows will remember, the guidelines should be evidence-based, and if the data were not there to endorse 140/90 as a target, then those writers opted not to do it, and that gave us the conundrum we have right now until Sprint shows up.
Okay, so this is really was a problem, and we are talking about 2013, but many things happened since. So at that time, it was a debate, and certainly it seems that with the criticism of accepting this higher threshold was all over the place, and I think all of you have written about actually, and about the black population, about the generalization, also about women. There have been a lot of articles saying that this could affect a number of populations by having the threshold so high. So I don't want to spend too much time there, but now go into what happened recently, which is quite interesting, and this is the Sprint trial. And we are now moving into part number 3. The first was peace, the second part was war, and the third, who knows. This is the Sprint trial. This is very, very worthwhile to go into some detail here. And I just, all of you know about it, but there are points to discuss. This trial, a multi-center trial of more than 9,000 patients with a systolic blood pressure of 130 millimeters or higher, and an increased cardiovascular risk. And the trial actually was a randomization in targeting a group into 120 millimeters of mercury or less intensive therapy in a group with less than 140, which was the standard therapy at that time. At 1 year, the mean systolic pressure was 121 in the intensive group and 136 in the standard treatment group. The intervention was stopped early after a median follow-up of 3.26 years, saying that the results were already very significant in terms of the intensive group. And this is how the results are being presented. And they say, first of all, the intensive group had, in terms of primary composite outcomes, was 1.6% per year, while the group less intensive was 2.19 per year. At 3 years was 5.2 versus 6.8. What is very important is how you read the journal. And actually I had this discussion with the editor of the journal 2 days ago. They write a 25% reduction, which means they took the relative, which is something you can fool anybody. The relative reduction was 25%. Then they go into the side effects, and they don't give numbers. You'll read them in the discussion. They say was a slightly more serious adverse events in the aggressive group than in the other: hypotension, syncope, electrolyte abnormalities, and acute kidney injury. But then you go into the discussion, and then you pull out the data, and the data is the following. Significant side events, 4.7% in the intensive group versus 2.5%. And then they are talking about an absolute reduction of 2.3%, when actually the relative reduction is 88%. This is a clear flaw of how we should read literature. They point out the relative reduction into the benefits, and in terms of the side effects, they point out the absolute reduction. And I'd just like to comment, Marianne, can you make a comment about this? How to read the literature, because this is quite fascinating. These people have significant side effects with a drop in the pressure of less than 120.
Well, as you said, that this is a common issue in analyzing literature, and we often use relative risk reduction when we're selling the trial. That's what we usually use. But when it comes to your individual patients, you want to look at the absolute risk reduction. It's actually a 0.6% per year reduction in mortality from the SPRINT data. So even though it was a marked relative risk reduction, but I agree when you look at the overall side effect profile, I think was also reasonable when you look at those participants who had electrolyte imbalances, hypotension, was relatively small compared to a mortality benefit. I mean, I think if the benefit, the combined endpoint included heart failure admissions, mortality from all-cause mortality or cardiovascular mortality, and cardiovascular events. And in that, what really drove the report, with the results, was that the heart failure and the all-cause mortality. So you would say, okay, the heart failure was defined as an emergency room visit or requiring medication. So it could be just a diastolic, HFpEF exacerbation requiring the diuretics. So that really drove this. But if you look at the reality, that is an important outcome in reducing heart failure. Interestingly, they excluded patients with ejection fractions under 35%. So really, the heart failure you're looking at is more of the preserved ejection fraction than the reduced.
It drives the data.
I think, and part of the treatment therapy was increasing diuretics. So if you look at the reality, people will argue that the absolute cardiovascular mortality benefit or overall mortality benefit was slight per year. I think the important thing from a guideline perspective and going forward is what is the impact across the boards. If we look at, when we talk about guidelines and we say 140 over 90, or when we thought about maybe going to 150 over 90, there's a slippery slope. So if you say the target is 140, what happens in the office is it's like, oh, it's 145, you're close to your target, right? There tends to be the slippery slope upward.
We'll get into this in a moment. The whole problem is lower you go, higher is the side effects, and then that you should know your patient. I would like to ask if each of you, here is 30 seconds, I cut you, I can tell you that. What is your interpretation of a SPRINT? Dr. Rosendorf.
A very impressive relative risk reduction for both the composite endpoint and all-cause mortality, but you're quite right that when you look at the absolute risk reduction, it looks like it's very small. So it really depends upon your perspective. Is your perspective the patient who's sitting in front of you in your office, or is your perspective the large universe of people with hypertension, both in the United States and in the world? And if you look at that, you are going to save lots and lots of lives by adopting the SPRINT criteria of less than 120.
And lots of side effects. Dr. Krakow.
I would agree with Val in the sense that this should be carefully read and not taken for granted, and do not accept the headlines of our colleagues that lower is better.
Very good. Okay, Dr. Yancy.
Decidedly positive, but uniquely so in a very high-risk patient population, and especially with regards to reducing the incidence of heart failure, an incredibly important clinical and public health benefit with tolerable side effects.
Okay, just let's go into another aspect of the trial, which is interesting. Dr. Felgers, do you know that by the exclusions of people under the age of 50, prior stroke, in diabetes, they only approach 20% of the population in the United States that have hypertension. Only 20%. The other 80% we do not know. What is your opinion?
I agree. So I think that there's this tremendous large population that we're not addressing necessarily. But in terms of the SPRINT trial, I was very encouraged because in terms of the patient, the subjects that were enrolled, that were well represented for African Americans, women, and the elderly. So I think that at least we can infer from the SPRINT trial that it's generalizable to the patient population. But I do agree with you that there's a large patient population that we haven't looked at.
Okay, I'd now like to go into what is most recent, which is a paper in the Lancet a week ago, and I think it's fascinating. This is by a very good group of investigators in hypertension. Dr. Dana Etehad is the first author of the paper. This is actually a meta-analysis of all the mess that we have been discussing, all these trials. And it's very fascinating what the findings, and I'm going to read the 4 findings, and then we'll go from here. First of all, they are talking about 500,000 participants of patients who have hypertension. The meta-analysis, regression analysis, etc., what they found is every 10 millimeters of drop in blood pressure has the same relative effect in terms of income, exactly with the statins. You can draw the curve. And that is, you can have a very high-risk population and you give statins and you drop LDL by 20 units, you have a relative impact that is the same that if you go 10, 10, 10 below. But the impact is much higher in the high risk because they have many more events. That's what they find. And actually it's fascinating because they say, we now enter many studies in which the blood pressure was reached less than 120. And what they say, absolutely what this SPRINT says, is true. That as you go down, there is no bottom. You drop the number of cardiovascular events, but you increase the number of side effects. And I think this is a very critical paper that makes you to individualize your patient. You just cannot say a goal is that, but you know that less than 120 is very meaningful. I'd like to ask maybe Kim, that you presented all of this. You probably didn't see this paper, but based on everything you read, it makes sense?
Yeah, definitely in terms of, I guess, interpreting the trial at face value, you have to really understand kind of the patient population that it was, that it included. So, and I think you also brought up an interesting point regarding the statin use, because there was actually based on the number of patients that had a Framingham risk score greater than 15%, more of these patients should have been on a statin. So there's a suggestion also that like appropriate medical therapy may not have been optimized as well prior.
Okay, now these are the 4 conclusions. Will be 2 that I will ask Dr. Rosendorf, and there are 2 that I will ask Dr. Yancy. Okay, there are 4 conclusions of the whole issue of blood pressure.
The study that you
No, just let me tell you the conclusions, and then you have the answer.
Yes.
I want you to answer the conclusions.
Right.
First, the findings suggest that the blood pressure lowering to levels below those recommended in current guidelines will reduce the risk of cardiovascular disease. That's number 1. And that is, they go even less than 120. It will reduce. They see all in the trial. Lower you go, more reduction of events. It's like the statin story. And the second comment that they made, by showing no evidence for a threshold below which blood pressure lowering ceases to work, the finding called for blood pressure lowering based on an individual potential net benefit from treatment and the risk that the individual may encounter by dropping the blood pressure too low. These are the first 2 conclusions. What do you think?
Me.
Yeah.
Just a quick point about that Lancet article that you've just quoted. It's nothing new to see that if you look at the epidemiology, the hypertension is a graded risk factor. And it is a continuous variable in terms of cardiovascular risk. So there's nothing magical about the numbers 140 or 90. In fact, 130, 80 seems to be better than 140, 90, and 120, 70 seems to be better than 130, 80 in terms of the epidemiology. Now, that's not the same thing as saying that you're going to get the same effects by reducing the blood pressure with medication in patients with hypertension. I think that SPRINT has done us an enormous service in showing that, in fact, you can lower blood pressure safely. And I think the safety aspect, quite apart from the hypotension and dizziness, there was not an increased incidence of falls in the elderly. And the cardiovascular benefit in the elderly was actually better, that is, over the age of 75, better than in younger patients. And there have been some metabolic problems, hyponatremia and hypokalemia. Not surprising, because probably they had more intensive diuretic therapy. There have been some...
Yeah, I'm sorry, because we really have to move on.
Okay.
You are in agreement with the first 2 points, and that is you can drop as much as possible.
Yes,
and you decrease the number of events.
I think SPRINT that was the death knell of the J curve.
Yeah.
In fact, in the range of blood pressures that we use for treating hypertension.
This goes against the J curve we were talking before, Kim. Last two conclusions of the paper. Third conclusion, the broad consistency of the findings across patients with or without prior vascular disease could help to simplify clinical guidelines for use of blood pressure lowering drugs for any kind of risk. This is fascinating. Means all these numbers in the patient high risk, forget it. You just drop the blood pressure as much as you can without side effects. Is you are in agreement with this? Let me tell you number 4. This is one. Regardless of the risk, you go for everybody. Fourth, the differences that we identify between classes of drugs. This is a separate question. Let's go into the drug issue in a moment. What do you think, Clyde?
My own sense from looking at this very carefully is that lowering blood pressure, regardless of the patient history, is important. But SPRINT tells us that especially in those at high risk, it's uniquely important. If everybody pauses for a moment and think about this, when was the last time as a clinician that you took out the Framingham risk score or the ASCVD risk calculator and for the purposes of treating high blood pressure, calculated the risk and said, because the risk equals X, I'm going to treat this person to a lower target? We've always used an empiric value of 140/9, and Cleve is exactly right. It's arbitrary. And so I really do embrace the notion that the higher risk group needs to have a more aggressive target, but everybody's blood pressure needs to be lowered within reason.
Thank you. Dr. Krakow, let's go into the final comment. It's about, they look at treatment, and their conclusion is beta blockers were inferior to all the other drugs, including calcium channel blockers and diuretics. Calcium channel blockers were inferior to any drug for heart failure, but were superior for the prevention of a stroke. And diuretics were superior, as we know, in patients with heart failure. I think this is something that I think is not new, but I think is interesting coming from a huge study like this. You are in agreement with that?
I am in agreement, and I think particularly with regard to the beta blockers in patients without coronary disease, which is a huge fraction of those we treat. As single agents alone, calcium channel blockers of the hydropyridine subgroup are probably the single most effective single drug class for lowering blood pressure. That doesn't mean I say everyone should get them, but those are the facts based on a lot of trials.
Okay, so we go into the last topic. We did the basic principles at the beginning, the history, which we just finished with the last paper a week ago. Let's now go into resistant hypertension. It is much more than the sympathectomy of the kidneys. Let's just discuss this in some detail. Well, first of all, I will make a few comments and then you people discuss it. What is resistant hypertension? Resistant hypertension is systolic blood pressure more than 140 or a diastolic blood pressure more than 90, despite of diuretics at a full dose and 2 other antihypertensive medications from 2 different families. I think we are not going to discuss this in detail, but I think that's basically how you define it. And here's where I agree with you that 24 hours ambulatory is the only way that at least everybody knows where you are. So I don't think there is a discussion here. Now, the third and the fourth point I think are quite critical because may explain part of why the sympathectomy has actually failed, the renal denervation, at least up until now. Number 3, you have to consider the vascular stiffness. And the vascular stiffness is age, chronic blood pressure, general atherosclerotic disease, diabetes, and chronic kidney disease. It is being said that by definition, you are not going to touch the sympathetic system in these people, which is a large number. And actually, when you go into the 3 studies in which renal sympathectomy was done, you have great questions because many patients were actually in this category of vascular stiffness. Now I'd like to ask you a question. I never understood, but I read about it, how you measure vascular stiffness. And there's a very simple way, and I'd like to know whether you agree or not. Dr. Olin is also there. Is the difference between systolic blood pressure and diastolic blood pressure. Simple as that. If it is more than 55 millimeters of mercury, you have vascular stiffness. Are you in agreement? What do you think, Dr. Olin? Dr. Olin was here. He was tired of this, and he left. Anyway, this is important because these patients, by definition, what they say, they are not going to be helped by any kind of sympathectomy approach. Anybody measures the stiffness in this way? Any of you here? You do, Larry? What do you think?
Yeah, pulse pressure is in older patients, I think, is it's the best we have in an office, instead of going into rather complex methods that are limited basically to research environments. But it is something that we measure, see it all the time. I'm sure everyone in the room is aware of it. You have an 80-year-old with 160 over 60 blood pressure. I would call that a stiffness.
And it's prognostically important.
Yes.
Okay, the second issue that is important that you will never win with a sympathectomy is if the patient is not taking the drugs, which is one of the key issues that evolved from the trials. And the other, if there is sodium retention by anything you eat, salt and so forth, you can call resistant hypertension, but actually it's not. And when you get into a trial, everybody takes care of themselves and things then vanish. So there is a second aspect, or maybe another aspect, that patients should be excluded for this sympathectomy. One is actually interesting, is a sleep apnea, which is so common, leading to hypertension, and actually to resistant hypertension. Sympathectomy would do nothing. The other is renal parenchymal disease or renal artery stenosis. And the other is primary aldosteronism with low drop in potassium or high aldosterone levels. But particularly the sleep apnea is quite important. And I'd like to, before we go into this sympathectomy, it seems to me that we are eliminating a large number of patients that would have failure to sympathectomy. What do you think, Clyde?
No, I think you're right, because the science would tell us that obstructive sleep apnea, at least, is a situation of hyperadrenergic drive. There's increased sympathetic activity. So that might, in fact, be a richer target for a sympathectomy, or at least denervation.
Dr. Felgers, it seems to me, though, that once we get into sympathectomy, renal denervation, we really have to make all these exclusions because, by definition, it would not work. You don't think that this, aside of some technical reasons, the sympathectomy was done not with the right devices and so forth, we don't get into the details, you don't think this might explain some discrepancy in the results of the sympathectomy 3 trial, for example?
Well, in my own anecdotal experience with our investigators here at Sinai, and I've referred several patients with sympathectomy. And I think that, while overall it seemed to have failed, I think that bringing the attention to the patients, I think that had contributed significantly to some of my patients actually having an improved blood pressure outcome. So I think that this study needs to be redone. It may need to include more patients, more diverse patient population. I think that it's a potentially good treatment for hypertension, one that should be looked into. But I wanted to kind of get back to something you talked about before in terms of whether patients are taking their medications, et cetera, and would this contribute to resistant hypertension. I think that that's very important because we're dealing with these types of patients in our clinical practices every day. Many of these patients do not have renal artery stenosis or some of the other issues that you're talking about. And so I think that the conversation has to be had in a way that patients understand culturally, sensitivity and things like that, to really recognize whether you're giving patients 5 medications and they're truly resistant or they're simply not taking their medications. So this is one aspect I think that should be looked into specifically.
Marianne, there are a couple of questions in finalize. Is that it seems that renal denervation probably should be individualized and first by exclusion of all the possibilities that might fail. So the judge is not out yet. Do you agree with that?
Yes, I agree that there are many patients that were not taking their medications that were included in the trial, and I agree with you about the sleep apnea. That's a controversial statement, but yes.
The second question is just to put things in the context of being an update. There are 2 studies that were presented in the European meeting, which are now going to be published in top journals, actually. One is the study from the British Hypertension Society, which is the use of spironolactone in patients with resistant hypertension. And the other, also from Britain, is the use of amiloride, potassium-sparing drug, also together with hydrochlorothiazide. What I'm really trying to convey is that not everything ends up with a renal denervation. But still there are possibilities by which we could be successful. Clyde, do you agree with that?
Resistant hypertension in the majority of cases is not really resistant. If you eliminate the problems of patient adherence, of physician inertia, and you increase the number of drugs, you up-titrate the drugs to maximum dose, you choose the right drugs, maximum dose, add a 4th drug if necessary, and spironolactone has been almost miraculous in dealing with that particular problem, because most of the patients who are so-called resistant hypertensives have aldosterone excess or are hypersensitive to aldosterone. So mineralocorticoid antagonists are absolutely marvelous in that context. Amiloride I don't have much experience of. Patients who become hypokalemic with other diuretics, I think amiloride is a reasonable choice. But spironolactone also would be a reasonable choice to add on to a thiazide diuretic. We don't use hydrochlorothiazide very much anymore, even though it's the drug which is used most in hypertension throughout the world, because chlorthalidone has by and large supplanted hydrochlorothiazide in most hypertension clinics. It's a better antihypertensive drug. It's more effective, and hydrochlorothiazide and also has a number of other effects which may be useful in terms of the vascular biology.
We have 10 minutes for questions. Yeah. Can you use the microphone, though?
If I have a 25-year-old African-American individual with a blood pressure systolic between 125, 130, with a very bad family history of hypertension, hypertensive, and vascular and organ disease, do I consider that person a pre-hypertensive and I treat him now before hypertension hits him and it will be much more difficult to treat, or not? Or at what point would you start therapy?
Dr. Yancy?
So, great question. Remember that the first treatment for hypertension is non-drug therapy. And so I'd make certain that we had considered all the possibilities. Diet especially, I am very persuaded by the DASH studies that demonstrated that uniquely in African Americans, changing the diet leads to an 11 millimeter of mercury drop. That's enough to change the natural history of the disease. So I'd work very diligently to make that happen. I am not opposed to doing secondary evaluations for hypertension, even in African Americans with a strong history. It's very interesting what you might find when you begin to look for other causes of the disease. But I would also exercise a low threshold to treat, especially if I use something like ambulatory blood pressure monitoring, which is infrequent in my practice, but if I used it in someone like this, and there was either evidence of an absence of the dipping phenomenon, or if I saw that there were transient blood pressures that were higher than expected.
Was not in your cardia study that you begin at young age and you follow people for 25, 40 years, and this patient that is presented tends to progress? Yeah. Other question or comment? Yes, Dr. Weissensen.
Should we be changing the time of day of administration of the antihypertensive drug? There's some evidence of late that perhaps
Dr. Krakow?
sleep is a good time.
Well, there are a number of papers, largely from Spain, actually, that indicate that nocturnal administration of ACE inhibitors and ARBs, the renin system blockers, might be more effective throughout the day, and this is based on 24-hour blood pressure monitoring. So I think there's a case for it. Outcome studies, I'm not aware of outcome studies which show that this there is better in the long run, but it's an intriguing thought.
This question, Sunil?
Dr. Fuster, can I make a comment
Yes, go
about
ahead.
the mind-heart connection that you usually like to talk about? And the SPRINT trial, there's a sub-study, the SPRINT Mind study that has not been published yet, but I think that will be a big motivator if we see a delay in cognitive decline in patients with more aggressive blood pressure treatment. In the HYVIT trial, the hypertension in the very elderly trial, there was a subset there looking at cognitive decline, and there was a non-significant 14% reduction in decline in cognitive skills. And I think this study, the SPRINT Mind study, is a more sensitive testing with MRA of the brain. So I think that'll be very important to motivate our patients to take the medications. When we talk about fewer than 50% of people actually take their medications as prescribed, I think the two things that this study does is it says, okay, actually 120 over 80 is now your target, so maybe they'll get to 130 if they think the target really should be lower. And secondly, if you say you'll prevent dementia, I think that that will definitely increase.
I agree. This will have a lot of impact. Yeah.
So Dr. Fuster and panel, I think I will appreciate some comments on masked hypertension. Like we don't see it as clinicians. So when to suspect it and what do you do about it? In which patient will you get 24-hour ambulatory monitoring for masked hypertension?
Basically, marked hypertension, you know what he's talking about, is the hypertension at home, but not in the office. Basically, any comment, Dr. Felgers?
I'll comment because this is a huge problem because it means that potential impact would be to do 24-hour blood pressure monitoring on the pre-hypertensive high normal group, which is the substrate from which masked hypertension comes. This is a big problem to be solved as to how to apply the technology we have without breaking the bank or misleading ourselves. So this really needs further study.
It's expensive.
But we have no data that treating these patients actually does anything. In fact, there's never been a study to show that it does.
Well, Dr. Yancy, I have a question for you which goes along with the, should everybody check the blood pressure at home? Not with this fancy machine, but you know, again, once a day, every year or so for a period of 7, 8 days. The incidence of hypertension is so high that it seems we are missing it.
So my bias is yes, that the general community should be very conversant about their blood pressure. But I think the one thing we're not identifying is that no matter what system you use, ambulatory, clinic, home, it's a bit of a cumbersome process. And I think there's an opportunity here to find an easier way for something that would be broadly applied. So we've been having some fun at Northwestern developing a wearable technology that can continuously and passively check blood pressure throughout the day. We've built a prototype uniquely because we believe that we don't have ideal ways to cheaply measure blood pressure reliably throughout the day without all of the variations that happen. So hopefully in another year or so we'll have some more information here about a very easy way to do this.
Thank you. Other questions or comments?
Yeah, just briefly, I wanted to just follow up to what Dr. Krakoff mentioned. We don't talk a lot about white coat hypertension, but I think that's important as well. And just to back up what everyone's talking about in terms of ambulatory blood pressure, we see a number of patients who come in and their blood pressure appear to be very elevated in the office. And what I tend to do is follow these patients with their ambulatory blood pressure monitoring and home blood pressure monitoring, because what ends up happening is in a stressful situation, their blood pressure is elevated. So it is important, even though they end up, you look at their diary and it tends to have normal blood pressures at home. The fact that the blood pressure is elevated in a stressful situation is an indicator of things to come. And you talked about that patient. I think someone asked the question of the young patient who had pre-hypertension but predisposed to worse outcomes because of the family history. This is the sort of the trajectory you will see with these patients with white coat hypertension. So I think you need to pay a lot of attention to that and continue to monitor in the home setting and ambulatory.
This is why, Silma, I think that the measurement of daily blood pressure for a period of days in establishing a mean, again, as a doctor, I think is quite helpful. And I think I am with you, Clyde. I think this should be almost universal, frankly, because our lives are quite different in a daily, over a number of days. There are days better than others, wherever it is. And I think you can get an average and get a sense of what is going on. Anyway, other question, comment? Yes, Dr. Dangas.
I just wanted to follow the comment of Dr. Felgers and Dr. Rosendorf that the sympathectomy warrants another go with another trial. The other trial has been approved by the FDA a couple of months ago, and 10 centers in New York, 50 centers around the world. It's a spiral study, and I hope we can get it done. We're the single center in metropolitan New York area.
Yeah, thank you. I think, as we said, the judge is not out, and there is a lot to learn about getting the right patients there. Well, I think it's finishing at 6:25. I really appreciate your attention and the speakers. Thank you.